So I did my lightning strike presentation on Jones fractures because I have three men's basketball players with who are recovering from Jones fractures at the moment. So I saw it very fitting to do Jones fractures or proximal diaphysis fractures. Sir Robert Jones was the founder of the Jones fracture. He called it a transverse diaphyseal fracture of the fifth metatarsal. He classified them in three different zones. The first zone, shown in purple, is the avulsion fracture. The second one is the actual Jones fracture or diaphyseal fracture, and the third one is the stress fracture, which is also a transverse fracture. Most of the transverse fractures or stress fractures happen in the third region, and then Jones fractures go about halfway through the zone 2, and then they either get surgery or choose the non-conservative or the conservative route. Because my population is men's basketball, I saw it very fitting to have a picture of somebody dunking because that is the most common mechanism of injury for Jones fracture is landing on the lateral side of the foot, putting too much pressure on that side of the foot, which in turn from that causes the fracture. Other mechanisms for this injury are cutting, which is a sudden change in direction, lateral movement, such as the side shuffling, landing wrong, kind of rolling your ankle a little bit, could cause it. Jumping could also cause it from the landing wrong, and sprinting. A lot of the articles like to say that planting your foot wrong while sprinting was a good way to cause a Jones fracture. Most of the articles also said that ankle sprains are the most common between both practices and games in men's basketball, due to the fact that they roll their ankles a lot. They have a lot of unstable shoe choices as well. So this is just kind of what a Jones fracture looks like. The two that are circled in yellow is an actual Jones fracture. It's an actual X-ray of someone with a Jones fracture. And then the most common treatment for Jones fracture is the surgical intramedullary screw fixation, which is the picture on the left. So they basically go in there and they put a screw into the fifth metatarsal. They measure your metatarsal first and then insert the screw in. And what they're basically waiting for the screw to do is cause the bone to reunite with itself. For the intramedullary screw fixation, patients are kept non-weight bearing for about 2 weeks, and then they're put in a Cam Walker boot after they remove the sutures after the 2-week period. Cam boots are what is the picture on the left. After they're put in the boot, patients can bear weight as comfortable, so it's to their tolerance. If they can't put weight on it, then they don't have to. They're not required to. Doctors do encourage the patient to try to continue ankle range of motion to make sure that the patient does not lose that. And then after radiographs confirm a full reunion, patients are allowed to resume full activity. It takes about 3 to, I believe it's 6 or 5 months for the reunion to occur and patients to be returned to play. The second option was a conservative treatment, which the people who chose this, their treatments either varied from no treatment at all, an elastic wrap, open-toed shoes, which is the middle bottom picture. They normally go to the hospital and they will give them those kind of shoes. The short leg orthosis, which is the picture on the right. It has a sole on the bottom and then lateral and medial ankle support to prevent any kind of inversion or eversion of the ankle, and or crutches. So if they aren't comfortable putting full weight on that foot, which I'm assuming that they won't be. They have the option of putting crutches on or using crutches, but depending on the severity, depends on what treatment they receive. Also, another non-surgical treatment that has been shown to work is shockwave therapy. Based off of the studies done, the Oscitron or OrthoWave 280 device are the most common for this kind of treatment. It does have a high success rate based off of research done and studies done. They put the patient under general anesthesia, and the recovery took about 4 to 6 weeks in a weight-bearing cast. Also, patients were encouraged to come in about every 2 to 4 weeks to make sure everything was going as planned and that there were no complications or anything like that. And as soon as a non-union or a reunion was confirmed, then the players were returned to play. The results showed that with Jones fractures, the surgical treatment was indeed the fastest course of action for an athlete to be returned to play. However, it did also have the highest risk of a refracture. But those who chose the conservative route had a higher risk or had a better chance of not refracturing it than those with the intramedullary screw. Also, another problem that came up a lot with the screw fixation was that the screw caused discomfort and they ended up having to go back in and take it out, or the screw being too loose or the screw not fitting the bone right, so causing discomfort to the patient as well. So yes, surgery does have the fastest return to play, but the conservative treatments have shown to have a higher success rate and a patient satisfaction rate as well.